understanding the community and the people that are there and the connections that you can build with other people. I'm also a very avid outdoorsman, so like activities that you can do. And so understanding what are the options kind of within a community to help support the health within that community, and also the surrounding towns and hamlets, depending on how small you are. Those are the things that really draw me to rural care, because you're able to do that connection and then also have the scope of practice that you can. The current, until like May, the current president of the Academy of Family Physicians for the country works in Valdez, Alaska. And so there are 6 physicians that manage healthcare for the entire town. They do all the emergency care, all the obstetric care, all the primary care, all the inpatient care. Absolutely anything that you can do in medicine, they do. And as a physician, to be able to float a transcutaneous pacer wires to keep somebody's heart beating, which is something that the specialists here at Concord have never done before, but I've floated probably 5 of those, is really special, to be able to have that kind of level of care, to be able to keep your population afloat, truthfully.
So one thing that I am not hearing is the support. I think it was pretty well illustrated in this film that it's very easy to get burnt out in a rural setting. And as much as you need salaries, as much as you need people recruiting you, as much as you need, paybacks on loans and stuff like that, you need that emotional support. I mean, when you're solo, I was solo for 13 years in northern New Hampshire. It's very easy to get burnt out. And, I ended up changing my life and going back and doing a fellowship and ended up teaching at the Concord Hospital for a while. But that's the kind of thing that not only do you need the front end, but you need the back end and support the people that are already there. So I would encourage you to expand your horizons on, you can get people there, but don't ignore the fact that people there need also ongoing support, because there really is none up there.
Is there another question in the back?
I just wanted to respond to that really quickly. So there's a lot of national talk about clinician and provider suicide and burnout, and there's a lot of discussion about this concept of joy in practice. And I have to be honest with you that we've tried to do those things and we can't get them funded. They're not what the federal government currently is interested in, unless we can tie it into something else. One of I think the avenues is there's a lot of talk about trauma-informed care. And the way that you become a trauma-informed care organization has an external component facing your patients, but also an internal component, which allows you to address and to fund and to resource that support. So I'm very hopeful that as we move towards that model, that we'll be able to sell that under our funding opportunities as an overall thing and start doing some of that work. But some of the hospitals in particular in this state have started to create groups around that, about how to do that support and that emotional support, and to really recognize the kind of wear and tear that takes on you, taking care of people. I mean, I was emotional watching this film. I'm not a provider and I don't know these people. And I can't imagine what it must be like, particularly that provider who felt like he's drinking a margarita watching people in quicksand. And I think that the same thing that drives people to do this kind of work also is what it sometimes is not very self-protective. So I am hopeful, and I definitely hear you. There's conversations about it. There's just no actual money connected to doing that work yet.
Question in the back?
So I actually have a bureaucratic comment, and then I'd like to comment on the film. My name's Holly Mintz. I'm a pediatrician. I'm with the Elliot Hospital. I am privileged to work with Dr. Elgert. I'm also privileged to have quite a few of the Concord residents now working with our community. So when we were speaking about workforce, I think one thing, and I'm a transplant here, by the way. I grew up in the state of Washington, and I've now been in this community for 22 years. And feel very, very incredibly connected. If anybody in the room is here that I know, you know that. I feel that way. This is my home. One of the things that we lack regarding workforce training is we lack a state medical school. So, the challenge with that, we have a medical school at Dartmouth, but it's private. We have students in New Hampshire who are interested in going into medicine. They are, there's no options for them in New Hampshire. They have to go out of state. They have to get in somewhere either out of state or private. They end up with enormous loans because there's no option for in-state tuition. In addition, our networks in the community don't get the opportunity to be exposed to medical students. I'm one of the very few people, I trained in Children's Hospital at Pittsburgh. I'm one of the very few people who left the Pittsburgh area. A lot of people will stay where they train, or where they go to school, because there's so much exposure to the community, the practices, etc. So I think, and I actually have been in a meeting with the governor before. I think we really need to provide our youth in New Hampshire the opportunity to attend a state medical school, stay here, be established here, stay at home, because a lot of them leave and they don't come back. So I just, I would love to know if you have any, kind of thoughts or comments on, what we could do to make this happen.
I'm acutely aware that we don't have a state medical school because I talk to my colleagues in other states and they're like, oh, we just make them do stuff. I'm like, ooh, that's nice. So barring that, we do an excellent job on a nurse practitioner and PA level and all of the other sort of complementary providers growing our own here. And there's some wonderful programs and they've been trying to meet the demand and staff up. Faculty is also a difficult thing to recruit for. So I sort of left that kind of like dream of a medical school behind and we've been focusing on expanding residency. Concord does a wonderful job, but we've talked to them over the years and they're not interested in doing something different than they're doing now, and that's great. So once we sort of have had those conversations, Portsmouth Hospital is starting a new residency program. And it's going to be focused on internal medicine, psychiatry, which is a huge need, as you can appreciate, and then I think some family practice physicians as well, and that's just started up. The other thing that's happened is for the first time ever in not that my career is that long, but in my career, the Federal Office of Rural Health Policy put out money to develop new rural residencies. And we do have an applicant who has applied on behalf of the state of New Hampshire to create a rural focused residency in the state. If that doesn't happen, we'll just keep pursuing it. I sort of have these legacy things I want to do before I retire in 20 years. And that residency piece, that supply, because you're absolutely right. What we know from research and evidence is that people stay within 50 miles of where they train. And what we know is Maine makes their own doctors and they keep them. And so as much as other people have shortages, at least they have a way to do that supply and to sort of tweak their system, and we don't have that, so we need to build our system. But I can honestly say, like I started out with earlier, there's nothing like providers and community members telling your governor and telling your legislator what your experience is and what you've heard works and asking for them to try it here. I'm an expert, nobody listens to me, and that's fine. I just write the grants. But when people from the community, I have so many legislators who call me and they had one person tell them something, and it makes a huge difference. We had one person complain to their legislator that they could no longer access the national program for loan repayment. And I explained why. It's a scoring issue on a national level. We don't look that bad, frankly. And so I said, well, we'd love to fund them under our state program, but we don't have enough money to do that. And some outside people pushed 2 bills forward. We got an additional $710,000 in this state to do that loan repayment. And we have 80 people on loan repayment this year, which is 4 times what I've ever had. So that's what I'm talking about. That's the power of, that's the great thing about having so many legislators that you have a personal legislator, but it's also the power of doing that. And so I can say that if you told them that and told them that there are evidence-based programs that we know exist out there and all we need to do is expand or get one off the ground, that would be a great push forward for us to be able to put some data together, put together some costs, and then present things from there. But there are there's some medical student experiences that happen. There are a lot of things that happen, but like, I know I sound like a broken record. It's very sort of like sporadic in areas, and they'll start up with 3 years of grant funding, and then they die because they're not sustained.
Well, if you can get me a meeting, I'm really happy to sit down.
Oh, you can get a meeting. You literally can you can call a legislator, or you every time someone emails the governor and complains about anything rural, I get that email.
Okay.
Yeah.
The other thing I want to say is, as I said, I am privileged to work with Dr. Elgert, and a couple years ago approached him to understand what the barriers were, for him to provide this care, and why aren't more people doing it. I think it's really important that we continue to show this movie to our providers in the state. I have to say, what the approach that we have been trying to take in our network is that, if somebody you wouldn't say, I don't want hypertensives in my waiting room. I don't want diabetics in my waiting room. Like, somehow we need people to, providers to understand that this is a medical problem that, like any other medical problem. I think, in my work with physicians, there's a fear because, for instance, in my generation, we weren't trained to do this. People are afraid to do it. They're afraid that the waiver issue is going to get them into trouble. They're afraid that they don't know how to take care of these patients. So I feel like the more that we can expose providers to this type of information, and the more that we can provide mentoring, I feel that people are just afraid because they don't have the experience. It's not, I have a lot of providers that, I'll say, do you want, you've received your waiver, do you want to start seeing patients? But they feel like they need that, that initial training. So the more that we can do to increase the amount of mentoring, I feel like, for our providers, I feel that people would hopefully be a little bit more amenable to starting to take on these patients. But I think, we have to continue as a state to educate our providers, expose our providers to information such as this, to help them understand that this is a medical problem like every other medical problem. And as Steve had kind of, touched upon, provide support for them. For instance, when you take care of diabetics, you have lots of resources to help you. You have diabetic, nutritionists, et cetera, et cetera. We need to make sure in our health systems that we're providing the support systems that the providers need to help care for these patients. So it's not all up to them. But thanks for hearing me out.
If I could just say something to that point. So as a residency, one of the things that I really struggled when I first started my training here was that we didn't have MAT training. So MAT training is buprenorphine therapy. So essentially it's the treatment for if somebody starts to have opiate use disorder. And I think as residents, we firmly believe that if you're going to provide any therapy, you should also be able to provide the counter therapy to that. So if I provide somebody with too much insulin, I should know that I need to give them sugar to get their blood sugar back to a normal level. And similarly with opiates, is if we are prescribing these medications, we should also know what to happen if people end up getting addicted. And so as a residency, we have really kind of fought hard to get this extra training, and so we have training that's going to be happening this March at the end of the month to make sure that everybody in the residency is trained and that we're able to now offer this to our, I forget how many patients we have, I think it's 24,000 patients, to be able to have that within our community, but also train the next generation of physicians in New Hampshire as primary care. I also have the luxury of the new program director in Portsmouth, Rory Richardson, is currently my pod leader, and so we've really been pushing him as well in that respect. And so the new Portsmouth program is also going to be starting with MAT as part of the core learning that's happening for new family physicians, because this is really a primary care issue. This should not be a specialist care issue. This should be on family physicians.
Thank you, Phil. Any other questions from the audience? Maybe we should just have a final comment on the film. What I really loved about it was just the humanization, as I said, of the doctors and the patients themselves, just making people out of them. I love when she picks up that pill bottle and says, a friend of mine gave this to me. He said, maybe you should get rid of that.
I like the $10.
Yeah.
It happens more than you know.
Yes. Oh yeah?
Can
get that over to the mic.
Here, I can bring it up.
Yeah.
It's like gym day today, so.
Yeah. So I've been wondering, with the federal money ascribed to the opiate problem and how little of it went to workforce, to develop the hub and spoke program. So I guess it came around sometime last year, but it took so long to do hub and spoke that wasn't inaugurated until the very end of the year. I don't know what the future of that is, but workforce in the communities, I think, really needs to consist of recovery workers who are paid maybe, if at all, a subsistence wage. But you have, treatment for a little bit of time, and it's maybe going to change a life or save a life, but it's not really going to change a life, sustained terms, because the environment in which recovering folks can find in a community in order not to return from where they came, that's what their survival depends on. Because if they detox and they get on their feet, they have to know that there's somewhere to go. Just as a parolee needs this. And so we have the same, because of stigma, the same as in the profession, the medical profession, we have the same problems in the community where there isn't that receptivity, embrace, welcome. It depends on recovery centers. And it seems we only have one per county. That's ludicrous to me. And they're maybe not staffed because we're not putting money into workforce for them to be strong enough. So if we strengthen one in every county. So does anybody have experience with that? Because I think that's what it is on the ground, and I don't know what the future of changing that is. And I'm going to talk to you about bills.
I don't have that much experience with recovery centers. I will say this is a chronic, lifelong disease. I tell people every day, the rest of your life, you wake up, you've got to make a decision that day whether you're going to be sober or not. And that's as long-term as a lot of these patients can figure out for them. It's like being a diabetic. It's like any chronic disease model that we talk about in healthcare. It's an ongoing, long-term kind of commitment. And there will be relapses, and that doesn't mean that you're a bad person. It doesn't mean that you're weak. It just means that that's part of the disease and what is happening in your brain. It is a disease.
Nobody says that they have to do it alone.
Right, right. And